Hi everyone, I'm Anugna Miriyala and today I'm going to present a case of ASD with Eisenmenger syndrome. Atrial septal defects are one of the common type of congenital heart diseases. It accounts for the 13% of congenital heart disease cases with a 2:1 female to male ratio. The most common type of ASD is the secondum type that is located at fossa ovalis. Less than 1% of the individuals develop severe pulmonary artery hypertension with shunt reversal, the so-called ASD Eisenmenger syndrome, which can lead to significant morbidity and mortality. Early interventions have been made possible by improvements in fetal echocardiography and prenatal screening. Nevertheless, some patients still may receive an ASD diagnosis as an adult due to incidental finding. So here I'm going to describe a case of adult female who experienced shortness of breath due to ASD and it led to Eisenmenger physiology. A 48-year-old female presented with chief complaints of shortness of breath since 3 months of NIHA class 3, which is insidious in onset, progressive, aggravated on walking, relieved on taking rest, associated with platypnea. Chest pain since 1 month, aggravated on exertion and relieved on taking rest, non-radiating, associated with palpitations and diaphoresis. On examination of this patient, pallor central cyanosis with grade 2 clubbing was present. Oxygen saturation was found to be 88% on radial artery. On inspection, pericardial bulge with apical pulse and pulsations in pulmonary area and mild parasternal pulsations are seen. On percussion, dullness was heard parasternally 1 centimeter along right border in left second intercostal space from mid-clavicular line to sternum. On auscultation, tricuspid area, systolic murmur with accentuation on deep inspiration and ejection systolic murmur was heard in pulmonary area. Bilateral basal crepitations are heard. Based on this examination findings, patient was referred for following investigations, and the findings are noted as follows. On complete blood picture and peripheral smear, there's microcytic hypochromic anemia. On chest X-ray, pulmonary plethora, cardiomegaly, and prominence of pulmonary artery and hilar area was noted. ECG shows right axis deviation with right ventricular hypertrophy and ischemic pattern in inferolateral leads. 2D echo shows dilated right atrium, right ventricle, pulmonary artery, and a D-shaped left ventricular with large ostium secundum ASD with bidirectional shunt was noted. There was also severe tricuspid regurgitation and pulmonary artery hypertension. Since 2D echo confirms the ASD, our patient was diagnosed with ASD with Eisenmenger physiology. She was treated with metoprolol and sildenafil. Based on these findings, the case has been discussed as follows. Pulmonary artery hypertension in secondary type ASD seems to be related to age, female sex, size of the defect, and status of ASD. Early recognition of ASD and treatment have reduced occurrence of pulmonary artery hypertension. Undiagnosed ASD frequently manifests as dyspnea with exertion, chest discomfort, palpitations, and occasionally right heart failure in fourth decade of life. ASD with Eisenmenger physiology are usually uncommon. Heart problems such as heart failure and arrhythmias cause morbidity and mortality in ASD-related PAH. Closure of ASD is not advised once Eisenmenger syndrome has developed. In order to lower right-sided pressures and maintain hemodynamic balance, medical interventions and avoiding events such as pregnancy are crucial for this patient's survival. And I thank Dr. Burney and California Institute of Research and Technology for giving me this opportunity and helping me in this case. Thank you.